I am curious about how we use the rich resources that we have in our country to take good care of patients. My name is George Goshua. I am a physician scientist and assistant professor of medical oncology and hematology at the Yale School of Medicine and the Yale Cancer Center.
I'd like to talk about that more, specifically knowing more about your recent research. But before we go into that, can you tell me more about your work overall?
So essentially, we pair our knowledge as physicians. My group is a collaborative group across more than a dozen institutions, heavily based in the United States, but we also have colleagues abroad as well. And so we work across a number of disease areas in hematology and oncology, and we look at diagnostics and therapeutics. So both sides. And we use our medical knowledge essentially to synthesize the problem areas that we see in terms of patients being able to access appropriate care that they need. Sometimes costs are used as a barrier for our patients. And then we use methodology insights, some of our mathematical models essentially, to be able to break through to the different stakeholders, let's say payers and other folks who are responsible for covering care for our patients, to essentially, in many cases, I feel like show them that the blue sky is blue, that, yeah, you really should cover this diagnostic test or you should cover this treatment because it really does improve the patient quality of life or patient life expectancy, whatever the case may be, because it depends on the specific problem.
Could you tell me more about your work with iron deficiency in women?
In hematology oncology, there's a lot of rare diseases, and we've done a lot of work across many of them. One of them that's not rare at all is iron deficiency, both non-anemic and anemic iron deficiency. It's a medical problem area that has been understudied for decades. And so I have a good amount of patients with iron deficiency. And invariably, there is a whole panoply of signs and symptoms that they exhibit. And treatment is really straightforward and easy, actually. But what is not straightforward and easy are all the barriers that exist to being able to actually counseled on treatment options and then to be treated appropriately as well in a way that aligns with the patient's values and preferences.
Can you tell me some of the symptoms that people have when they are iron deficient?
But in terms of iron deficiency, this is the hard part, right? So a lot of them align with what we experience as adults, I feel like, in terms of everyday wear and tear, so to speak, as we get older. So some of the symptoms include fatigue. You can have a little bit of dyspnea in some cases, so a little bit of shortness of breath in some patients. Some individuals have cravings for ice that they can't quite explain. I've had a few individuals, and not just me, all of our colleagues, who also even have cravings for quite rich in iron, even things like soil, if you can imagine looking at that and being like, oh, that's appetizing. Shouldn't be, that's not normal. Hair thinning, in some cases, hair loss, and restless legs at night. These are some of the symptoms. The problem, of course, is that all of these can be part and parcel of everyday life, right? And so you won't know if iron deficiency is the cause or contributing to it without getting testing. The beauty about testing is that's actually relatively straightforward and actually highly specific, meaning that if the particular test shows a low enough value that's consistent with iron deficiency in pretty much 100% of cases, very close to there. And maybe the case, there's a subset of individuals in whom those symptoms will persist regardless of iron deficiency. That's true, right? Because two things can happen at the same time. But in a good amount of cases where we truly detect low ferritin levels, which I know that we'll get to, and treat folks, they tend to see improvement often within weeks to a month or so.
Tell me about the treatments then. And I know that reading a little bit more about your work, the article about it is that there are some treatments that are maybe difficult for people to take.
In terms of treatment, if you're diagnosed appropriately, let's say you have a sufficiently low ferritin value and your signs and symptoms seem to align with iron deficiency, treatment really is treatment with either oral supplementation, oral treatment. So you're taking an oral iron pill. Typically, we ask folks to take one oral iron pill every other day. In the past, many decades ago, or even as recently as the last decade, we used to ask folks to take oral iron 3 times a day or oral iron once a day. And then we realized that the body metabolism doesn't work that way, really. There's a molecule in our blood that goes up that essentially inhibits the opportunity to absorb that amount of oral iron. And so we know that we as humans absorb oral iron basically on and about roughly every 48-hour schedule or so. And so any extra iron that we give essentially just irritates the GI tract. And so for that reason, we've come away from saying, you need it 3 times a day or you need it once a day, and really ask folks to replete essentially once every other day. And I should say too that these are all available over the counter. The problem in part is that GI side effects in particular are not uncommon, and it depends on the exact study that you look at, but we see rates of discontinuation or adverse events of oral iron, specifically things like abdominal pain, constipation tend to be the big ones in about 40 to 50% of folks. And a good subset of them will just stop taking the oral iron, right? And there's something to be said too about, I suppose, being in a doctor's office, right? And getting a treatment, whether it's an infusion treatment or whether it's subcutaneous injection under the skin, as opposed to, let's say, taking something like oral iron. So there is also a subset of individuals who may not realize, right, if they haven't been counseled appropriately, that this is a significant issue. And especially, it would be fair to categorize individuals or women who are pregnant as a particular priority area. There's some good data to show that iron is particularly important in pregnancy, but not just in pregnancy. And of course, all the women who are iron deficient, right, the ones who choose to become mothers will face this, right? And their babies will need a lot of iron in utero. And then there's intravenous iron. And we know that essentially we can administer intravenous iron directly into the vein. There's several different formulations, just like there are of oral iron. Some are given over multiple different infusions where you have to come back several times. And then others really allow you a one-time infusion. Of course, those tend to be the more expensive iron options, and those tend to be the ones that insurance companies don't want to approve because of the expense. And that's what we spend some of our time fighting against, especially for folks whose values and preferences do align with going the intravenous iron route. There are folks too who are truly iron deficient who say, doc, I don't want to quite yet do the IV iron. I don't want to quite yet even do the oral iron pills. Let me just try to take care of this with my diet by taking in essentially enriched iron foods. And so that's kind of like a whole spectrum of options. I would say that's about maybe 5 to 10% of our patients. And maybe about another 30 to 40% are interested in the oral iron route. And typically the rest are interested in saying, okay, you know what, doc, I prefer to just do this ideally one-time iron infusion and not to really have to think about this for a while again until whenever and if my iron stores become low. Some women in particular like to use it in a way where they essentially get their iron stores repleted and then from there on try to increase their iron intake with enriched foods. So there's a few different ways to do it. But the number one issue that we tend to see is that a lot of patients come to our clinic in hematology, at least anyway, having been iron deficient for years, not knowing the reason why they've been having symptoms. And that is a problem because that's incredibly treatable.
What are the risks of being iron deficient?
Yeah, no, that's a great question. So why does it happen in the first place and how long can it go on for? We do disproportionately see iron deficiency in women. The reason why, in heavy part, has to do typically with losing iron on a daily basis. So we start to see it within a couple of years of typically when a teenage girl starts to menstruate. Once menstrual periods become regular and have a regular flow. Part of the problem too is that there's a lot of women who have heavy menstrual bleeding, and we as a medical field don't do a good enough job actually quantifying it. It's been a taboo topic for many decades, essentially. And some of the original studies that actually normalized ferritin reference ranges for what is quote unquote low in terms of iron status included women who were iron deficient. So here we are trying to correct a problem from decades ago. So what happens essentially, let's say around the age of maybe, I'm going to say 14, 15, 16, 17 onwards, is that two things. One is that a teenage girl and who then becomes a woman starts menstruating. On top of that, the typical recommended dietary iron intake, a lot of women don't hit that mark for what is recommended. But the ones who do hit that mark, there is a good subset of them that will have heavy menstrual bleeding that essentially is undiagnosed, untreated. And so even if they're hitting the iron requirements as recommended on a daily basis in terms of the oral iron intake, they will often get into what we call essentially a negative iron balance. So every single day you're swimming upstream, trying to get to the beach essentially, and you never quite make it there. And the tide keeps pulling you farther and farther out, especially if you add on the heavy menses component. And so this can go on for years. It typically goes on for years before someone recognizes that there's an issue. Part of the reason why is because typically when we all go to the doctor, our primary care physicians, if they check blood work, they will often check a complete blood count, and that will reflect the amount of red cells in your blood. But the problem in part is that you don't have to start losing your red cells, i.e., you don't have to start becoming anemic until basically the very, very tipping point where you're essentially severely, severely iron deficient, especially when you're young. So the way I try to explain it to folks is I say, think about essentially making a soup, right? And you need all of these ingredients to make a good soup. And if you don't have one ingredient, right, sometimes maybe you can compensate for it by adding other ingredients to still trying to make a hearty, good soup that's enjoyable for everyone. When we're young, we can get away essentially with using other nutrients to try to make those red cells without necessarily dipping into a point where we start to become anemic. Our reserves are much lower when we're older. So for that reason, it's much more common that as we age, we finally start becoming anemic. And what we often see and what we'll see in clinic is typically women in their 30s who have now become anemic, sometimes women in their 40s who have now been anemic for 5 to 10 years. And this can be anemia that has been mild. Sometimes it's a little bit more than that. And in some cases, it's actually severe anemia that has been explained away by other reasons, but iron studies were never checked. And so essentially, it's kind of inertia, right? It just continues and builds up until you get to this point where a test that a doctor actually checks, which is the hemoglobin, becomes sufficiently low. Then we start to say, okay, we need to actually, explain this. Now, there's a few things that compound this and make this worse. So let's say a woman decides to become pregnant in her 20s or 30s, or at whenever she feels like it's the right time for her. If you look at the World Health Organization, they also have normalized lower hemoglobin values in pregnancy for women rather than men. This has no basis in scientific facts, and this is something that our field has also tried to address. But then essentially what happens is that if a woman enters pregnancy iron deficient, then inevitably, as she becomes anemic during pregnancy, especially as she heads into the third trimester, because the baby is siphoning off a lot of iron, we finally start to see that anemia. But then in a subset of women, we'll just say, oh, but that's normal because women are supposed to have a somewhat lower hemoglobin in pregnancy. Again, iron tests are never checked. The baby is delivered. And then what we see is we also see higher risks of bleeding after delivery, postpartum hemorrhage, specifically in the context of iron deficiency. That's yet another risk. This country is about 40th or so in the world for maternal morbidity and mortality. And postpartum hemorrhage, so bleeding after delivery, is one of the main reasons for this. And we know that iron deficiency contributes to it. We don't know the attributable fraction exactly. So just exactly how much it contributes to it. Is it 100%? Is it 50%? But we know it does contribute to it significantly. There are studies to show that. And now finally, there are studies, the first prospective study that looked at women who are iron deficient. This is based in Ireland, who were iron deficient at delivery. And then they followed their babies as they became toddlers and administered neurocognitive testing, showing that at about 2 years, there's worse neurocognitive performance across a bunch of different neurocognitive tests, specifically to babies born to women who were iron deficient at delivery. And so essentially then you have something that is in theory easily mitigated because it can be tested for in a straightforward fashion, but is typically not tested for. And in addition to that, there's problems in interpreting ranges for the ferritin, as I noted, right? Because those ranges were made way too low decades ago, and we're trying to reverse that problem. So some women who are tested then are never diagnosed, and so they cannot be treated. And so then you have all of these signs and symptoms that I talked about. In addition, then you have the risks in pregnancy that I just mentioned. And then now risks to also babies, right? And then it becomes intergenerational in a way, right? So we don't know yet what happens beyond 2 years in this prospective cohort. And we're going to need more studies, and we're going to need more studies in the States as well. But if it's true that these toddlers may potentially not recover those neurocognitive outcomes, right? And we don't know that for a fact one way or another yet. But if that ends up panning out, then you can imagine a world where a woman who doesn't know she's iron deficient gives birth to a baby boy or a baby girl. There's worse outcomes there. The next generation, typically, we all strive for the next generation to do better than us, right? That's normal. That's what's supposed to happen. Our kids are supposed to be better than us, but they can't quite hit that mark, right? If they've been saddled with an unnecessary issue. And then you see this intergenerational impact, right? And so those are the concerns that the experts in the iron deficiency field around the world talk about.
It sounds like there are a lot of risks and a lot of problems related to iron deficiency. And as you mentioned, it is for younger girls. Basically, they're just starting to menstruate, but also for pregnant women. And then later in life, also, what are some of those risks for women?
So it becomes a different issue at older ages. And specifically why, in part, is because you then need to understand why somebody's iron deficient, right? So I'm going to walk both through men and through women. So if a woman is truly postmenopausal and her periods have stopped for good, then she has lost the one thing that's been present for 30 plus years that's been making her go into a negative iron state. Once that's lost, assuming that if she was iron deficient, she was properly treated in the past, if iron deficiency recurs, there's a reason for that. It's the same thing for men. And it's important to investigate why that happens. There's many different reasons, from absorption standpoints to colorectal cancer. That's why we get colonoscopies on a regular basis, starting at a certain age, where iron deficiency, especially if it presents for the first time, let's say in your 50s and 60s, is typically a sign of something else. And so for that reason, of course, you need the treatment component. But at that point, at slightly older ages, it becomes about figuring out why you're truly iron deficient, just to make sure it's not something that's a problem for you. And then assuming it's something that's not a problem for you, assuming it's something that purely is an issue of, let's just say, losing iron in the gut for other reasons, because that's the other area where we will lose iron, right? And so if we're losing iron in the gut, let's say for non-cancer, non-colorectal cancer reasons, and there's many of those, and if it's a continual process, then you're going to be continually in an iron deficient state. And the problem in part with that is that as older adults, as I alluded to before, we don't have the same reserve as we did when we're teenagers and when we're in our 20s and 30s, just kind of like with the joints, right? Wear, tear, same thing. Now we are much more likely to become anemic. At the same time, in a way that's good, only in the sense that then physicians will pick it up often, right? We complete blood count because that's routinely checked for. But the problem is, let's say if you're not going to the doctor on a regular basis, let's say on an annual basis or something like that, and you do become anemic, that will then lead to many other problems, right? We know that anemia contributes to worsening a lot of other wear and tear diseases that we have, and it depletes our energy levels. If it becomes deficient enough, we certainly have a higher risk of mobility issues and falling. And these are the kinds of things that ultimately can kill people in their older life, right? We always worry about falls in elderly adults.
So, for a case like that, a woman who is young with a heavy period, can they possibly eat their way out of iron deficiency?
Yeah, that's such a great question. Right? This is where the discussion of values and preferences is so important. So it really depends on exactly how heavy the menses are. But by definition, there's a minimum cutoff in terms of just like cc's or milliliters of blood of menstrual flow. And if you look at it even purely from a mathematical standpoint of iron in and iron out, which is actually comes quite close to the reality for iron metabolism in particular, it truly is what we take in and what we lose, then basically there's going to be very, 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 very few women who can truly, with an enriched type of iron diet, deplete themselves. I often, when I have these conversations with patients, the folks who want to try it themselves, that's not an issue, right? That's not an issue. You're 20 years old. You're not planning to become pregnant. Let's say we know that you're iron deficient and you're not anemic at this point, right? And maybe you're having some signs, or maybe you're not even yet having signs, but you want to give it a try, right? And so what we'll often say is, let's give it 3 to 6 months. Let's see what you can do with an enriched iron diet. And often these folks will meet with nutritionists as well, just to go through, what are typically enriched iron foods. But here's the problem. The problem is that our bodies are made to limit how much iron we can take in. There's evolutionary thoughts behind why this may be the case, but the bottom line is that same molecule that I referred to before, which is called hepcidin, it really does upregulate. It goes up when we're taking a good amount of iron in, and it really doesn't allow us to take in if we were already have been iron deficient for years, right? It's a different story entirely altogether if it's maintenance, meaning that you're not already significantly or severely iron deficient. And all of us can keep up with our iron dietary requirements if we haven't yet become severely iron deficient. But once we have, at that point, especially when you add on the heavy menses component, it really becomes incredibly hard to catch up with purely enriched iron diet. There are a number of women, if the menses are low enough, that can catch up at least with oral iron, like an oral iron pill every other day, assuming that, they have a sufficient good enough gut absorption, because everyone is a little bit different. And again, we typically recheck in 3 to 6 months to see how it's going. But let's say in 3 to 6 months, if your ferritin is getting even lower and you've done everything, right? It's kind of similar to cholesterol in men and women, right? Typically, what will doctors say, especially if you're young, in your 20s and 30s? Do your best, often with a Mediterranean diet, get your exercise. Let's recheck in 6 months. If your cholesterol is getting worse despite your best efforts, at that point, let's help you, right? Let's do something else in addition to, right? Doesn't mean that you have to stop your enriched iron diet. Let's say we've been able to address the reason why you're having heavy menses, right? Or to address the heavy menses and we've repleted you. It's not unusual then for folks to be able to just keep up, either with an enriched iron diet or with an oral iron every other day, just depending on individual values and preferences at that point.
Because of our body's limitations on regaining and from supplements or eating additional iron, is it very important that we don't find ourselves in being in iron deficiency?
The place that we're trying to get to essentially is that this shouldn't have to become a significant issue later in life, as in that if menses are heavy, or maybe the dietary iron intake is not sufficient, or maybe both are happening at the same time, which we see quite a bit in teenage girls, especially, then we're in a place where we can address one or both early on. So you don't have to go on to develop, severe iron deficiency. It is important to note here too that the reason that young girls become anemic is not 100% of the time iron deficiency, right? There can be other reasons. And there's one in particular, essentially cousin process, so to speak, the thalassemia family of diseases that run particularly prevalent in certain ethnicities. Let's say around the Mediterranean basin is one example, where a girl can be anemic, but not really actually have iron deficiency, but instead have thalassemia, right? And so, in fact, that is in a state where taking in oral iron would be inappropriate and potentially damaging over the lifetime. And so, for that reason, there are folks who've said, okay, why don't we, everybody, especially teenage girls, empirically some oral iron? And that's part of the reason why not to do that. As in, testing is very easy. It's blood testing. It's very inexpensive, thankfully, overall, and incredibly accessible. Primary care doctors order ferritin testing without any issues. And if the value is low enough, then we can just confirm that truly, okay, this is iron deficiency as opposed to something else. I think prevention obviously is a big deal and something that we don't do well enough, I think, in the United States, right? Medically, I think we're very reactionary as opposed to preventative. And it's definitely an area where, as a hematologist, at least anyway, on the clinical side of things, I see folks who've been iron deficient for a long time now. And I try to get them to a point where they're not iron deficient anymore. And now they're just in their hands of their primary care physician and they can focus on prevention, right? By taking in those enriched foods, or a little bit more commonly, typically, especially if we're talking about heavy menses, because typically enriched iron foods are not enough in and of themselves. But again, you can track that easily with the blood tests, right? The oral iron every other day, once we've confirmed that they're iron deficient. So yeah, I agree with you. I think prevention is important, but to get to prevention, you need to be able to actually diagnose it, right? And part of the reason why we have this issue in this country is there's basically a few different, and this might be a little bit more boring, but it's a critical issue. The laboratory testing, there's essentially a few different assay types around this country. Around the world, actually, there's not more than 5 different assays that are used. The problem in part is that the clinical decision limit, as in the lower number of what is considered to be iron deficient, is vastly different across states and even within states. And this is something that the American Society of Hematology is actually working to fix. And the reason why iron deficiency essentially has been this pandemic that's largely been silent is because even when women get testing and they're truly iron deficient, there are lab assays out there that will call it normal, you know? And it doesn't flag with a little red flags. You don't actually know that it's abnormal. And that's the other reason why the American Society of Hematology has been working on putting out guidelines for what is truly an iron deficient ferritin. And they're focused on reproductive age women, they're focused on pregnant women, and they're focused on older adults, men and women. And finally, the last group that we haven't quite gone to, where there's a little bit less data, but is equally important, specifically kids around the toddler age, 2 to 3 to 4 years old or so.
What is the difference between iron deficiency and anemia?
So, iron deficiency is the first stage of iron deficiency anemia. Iron deficiency without anemia is sometimes just called non-anemic iron deficiency. All of the risks that I discussed earlier apply still to non-anemic iron deficiency. If you allow it to fester long enough, like a wound, it will lead to anemia. And anemia is a lower red cell count in your blood. The reason why it's so critical is because we're used to, as physicians, to test a complete blood count, but that only purely tests for the anemia component. It does not at all test for the iron component. And it's for that reason entirely, because ferritin testing, that's what we mean when we're referring to iron testing, because ferritin is a molecule in the blood that reflects your iron storage levels. That's why ferritin testing is such an important test, because it allows us to say, okay, you are truly severely iron deficient. And in young individuals in particular, young men and women, again, disproportionately young women, your ferritin can truly be undetectable. You can't even detect that there's any iron in the blood, right? But you haven't quite become anemic yet. And that is why the American Society of Hematology, as well as other organizations that they're working with, finally, as of the last couple of years, are putting together this magnificent international effort, starting here with the United States, to really make individuals aware that, hey, this is what ferritin is. This is why ferritin matters. This is why you should ask your doctor for a ferritin test, because it's an easy test to get. And if it's sufficiently low, it's easy to interpret to confirm that you have iron deficiency. And then you can actually, and only then, can you begin an informed discussion about what your options are, in terms of getting it corrected. And particularly important, getting it addressed, ideally, if you can, if you're a woman who's contemplating pregnancy before or as you head into pregnancy. So then you don't have to really think about it as much during pregnancy.
What would you say are the ferritin levels that are considered normal? And is it by age and the more complex, so people should get more information, or can you mention it now?
Yeah, so I can mention it because the American Society of Hematology tentatively released what the thresholds will look like at their essentially oral session at the big international meeting that we have every year in December. It will depend in part on, as you noted, whether you're a child or an adult. But in particular here, at least what I can notice, that a ferritin threshold of less than 30 is what they're going to move forward with, unless that gets changed. It's possible it gets changed in the revision process, but what they announced was a ferritin threshold level of 30 or less as being consistent with iron deficiency for reproductive age women, for pregnant women. And so there are caveats on top of that, which is that if you have signs and symptoms that are consistent with iron deficiency and you have a slightly higher ferritin than that, that could also be consistent with iron deficiency. But 30 seems to be, at the very least, a pretty safe ballpark. And the reason why we can say that in part two is we see that over the last several decades, when we look to confirm, essentially, we see that it's not 100%, but very close to 100% of individuals that are ferritin less than 30 truly have some element of iron deficiency. Now, not all of them are severe, which is fine, right? But the idea is that you identify them then, so then they can make informed decisions about whether they want to try an enriched diet, whether they want to do oral iron every other day, or whether they want to move forward with intravenous iron. But again, that it's going to be a values and preferences discussion, with their physician. But less than 30 is what I would pay attention to.
This has been so fascinating of a discussion and so informative. And why have I not known some of these things before? And maybe it exists online and maybe it exists places, but I have not heard it. So I imagine there are many people that will benefit from it. So I thank you. Thank you so much.
Curious by Nature is a production of Newswise. More than 7,000 journalists get the Newswise wires. Visit newswise.com and find out how to spread your news today.